cold and windy Prague. We are here from London and Prague. Online, I am honored to introduce Pat O'Brien from London and Martin Hinek from Prague. And those who joined us will listen to the problems caused by pandemic of COVID-19. You know that we all were facing a very specific and special situation last year, which is still ongoing, and unfortunately we do not think it will end very soon, but we have to cope with it, and we have to cope with the consequences for not only for general population, but also for pregnant women. So we will now spend an hour talking about the topics regarding the perinatology. Our first speaker today will be Professor Pat O'Brien, who is chair of the International Division of the Institute of Women's Health. He's consultant in obstetrics and gynecology at University College London Hospitals and vice president for membership at the Royal College of Medicine in London. Pat, it's your turn, please.
A real privilege to be here. Thank you so much to the organizers of this meeting for inviting me to take part. I would love to be there in person instead of here in wet, cold, windy, wintry London, but maybe next year, who knows. And I'd just like to say thank you to Martin as well and Pavel for allowing me to go first. I'm on the lay board and it looks like I'm going to be heading to an emergency in half an hour. So thank you for allowing me to go first. I'm sure all of you will understand that. Now, I'm just trying to advance my slides and they won't advance. Okay, fantastic. So my talk is focused mainly on the indirect effects of the pandemic. So not the effects of the virus itself, but just for context, I'm just going to spend a few minutes talking about the direct effect of the virus. In other words, if you get the virus and infection in pregnancy. And back at the start of this, so last year we published this study in the British Medical Journal looking at all women admitted to hospital in the UK who actually had a positive diagnosis of this infection. And then we did a meta-analysis which we published in the Lancet eClinical Medicine, which put together all of the available data at that point. That was around September of last year, and that included the study that I've just shown. And at that point, our understanding was that all the risk factors that were showing up in the general population for bad COVID, for ventilation and death and so on, were also the risk factors that were becoming prominent in pregnancy, the ones that you see there and that you're very familiar with. At that point, we understood that it seemed to be a little bit more common in pregnancy that if you got COVID, that you would be admitted to intensive care or intubated or indeed die, although the numbers were small. And it also seems that your chances of getting bad COVID or admission to intensive care was higher if you had comorbidities, in particular diabetes or hypertension, but also if you were a bit older. So very much mirroring what we were seeing in the general population. But probably the best place to see information about the direct effect of the virus in pregnancy is this. This is the Living Systematic Review and Meta-Analysis from the WHO group based in Birmingham in England. And Living Systematic Review, as I'm sure you know, means that as more and more data and more studies are published, that this is updated to keep track of and keep up to date. And that study, this was September of last year, suggested indeed, probably if you're pregnant and you get COVID infection, you're more likely to end up in intensive care. So at that point, our understanding of the effect of the virus was that the risk factors for getting bad COVID are similar to those in non-pregnant individuals. At that time, we thought it's no worse in pregnant than in non-pregnant women of similar age, although perhaps a little bit more likely to be admitted to intensive care. And it seemed that the risks of preterm birth and cesarean section were possibly increased. But interestingly, it was not that the virus was causing preterm labor, but that the virus was causing iatrogenic preterm birth in a proportion. And thankfully, at that point, it seemed that babies were not infected. Now, this is the updated version of the Living Systematic Review on the 10th of March of this year. And the conclusions, which I think are the most up-to-date of the direct effect of the virus, are that if you're pregnant and you get the virus, you are twice as likely to be admitted to intensive care or need ventilation or ECMO. Your chances of preterm birth are increased by a factor of 1.5, but most of those are iatrogenic births. The chances of the baby being admitted to NICU, intensive care, is increased by a factor of 5, mainly due to the effects of being born preterm, not due to the viral infection itself. And your chances of stillbirth seem to be increased by a factor of 2.8, although the numbers were very small. And in fact, the Living Systematic Review did not focus on that. Even in the abstract, it didn't mention that. This paper is published just yesterday, so this brings you right up to date. Asma Khalil, who's speaking a bit later today, is the primary author on this paper. And this looked at 340,000 births, so a huge number of births in England during a large part of the pandemic, 3,500 of which were tested positive for the virus at the time of birth. And that showed that the risk of stillbirth increased by a factor of 2, increased risk of preterm birth doubled as well, preeclampsia increased by 50%, and emergency cesarean section increased by 60%. So that's hot off the press from just yesterday in the American Journal of Obs and Gynae. So that's the effect, the direct effect of the virus, just to recap on that. Now, I'm going to spend the rest of my talk talking about the indirect effect of the pandemic. In other words, people, not the direct effect of infection itself. And I take you back, first of all, to July of last year, when we published a small study in JAMA, looking at the incidence of stillbirth in one hospital, St. George's Hospital in London. And what it showed is this. If you look at the column on the left, this is pre-pandemic period. And here, this is the pandemic period. And before the pandemic, if you look at the numbers in brackets, the rate of stillbirth in this hospital was about 2 per 1,000, whereas during the pandemic months, the rate of stillbirth was 9 per 1,000. And even if you excluded late terminations of pregnancy for fetal abnormality, the pre-pandemic rate was 1 per 1,000, and the pandemic rate was 7 per 1,000. So we acknowledged in this paper that these were small numbers, just one center, but we highlighted that this might be an important feature of the pandemic, because none of these women who had stillbirths actually had viral infection during their pregnancy at all, or at the time of birth. So the suggestion for the first time was that this pandemic somehow was causing harm to babies that was not directly due to infection itself. And there were some other studies published at the same time that suggested the same effect. There was one from Nepal and then one from India suggesting the same effect. And we tried to understand why this might be happening. Was it a change in the services that the hospital was providing? Was it a change in behavior of the women? And we looked at this study, which we published in Lancet Infectious Diseases, looking at the attendance of women to the emergency unit, the emergency obstetric unit, with things like a bit of bleeding or high blood pressure or headache or reduced fetal movements. And the blue line is in 2019, before the pandemic, and the red line is 2020, during the pandemic. Especially the dip there we can see was when after lockdown began. And you can see the huge difference in the attendance at this obstetric triage service, suggesting strongly that women were choosing not to come to hospital with conditions that they normally would come to hospital, like reduced fetal movements. And that was partly perhaps because of fear of getting infection. Every time you turned on the television, it said, keep away from hospitals, people are dying. So I think women were afraid. And also, I think they saw that hospitals were very, very busy, and they were, out of the goodness of their heart, they were trying to stay away from hospital and not increase the burden that was on the health services. So you can see a dramatic reduction in attendance at obstetric triage. And they went on, the RCOG, we went on to do a further study looking at obstetric services right across the United Kingdom. And you can see a huge, dramatic change in the services that we were providing to pregnant women. So 70% of obstetric units reported a reduction in antenatal appointments, also in postnatal appointments, home births, births in midwife-led care units, a dramatic reduction in emergency antenatal admissions, and a big change over to virtual consultations. So that was stillbirth, and I'll come back to that in 1 second. At the same time, there were lots of studies about preterm birth, and interestingly, studies suggesting that the risk of preterm birth seemed to be decreased from Denmark and from the Netherlands and from my country, from Ireland. Now back to stillbirth and preterm birth. So kind of alerted by our studies, the Office for National Statistics, the ONS in the United Kingdom, looked at stillbirths in England and Wales. That's the chart on the left. And reassuringly, did not seem to find any increase in stillbirths when they looked at national figures over the pandemic period. So that was quite reassuring, but there's more to say about stillbirth in 1 second. And on the right, looking at different rates of preterm birth, and you can see the different lines represent the different categories of preterm birth, stretching from 2011 right up to 2020, and no significant difference there. So there was a bit of reassurance from the Office of National Statistics. However, this year, just last month, we published this study in the Lancet Global Health, and this was looking at studies from right around the world, looking at the indirect effect of the pandemic. In other words, looking at outcomes pre-pandemic and comparing them to outcomes during the pandemic. And we excluded from this meta-analysis, we excluded studies that looked at people with infection. What did we find? Well, if you look at stillbirth, and you look at the bottom diamond down there, you can see that it's to the right of the line. And what that showed is that if you take together all countries involved in this study, right across the world, that there was a 30% increase in stillbirth during the pandemic. But if you separated that out and looked first of all at countries that are low and middle income, you find, yes, a statistically significant 30% increase in stillbirths during the pandemic. But if you look at stillbirths in high-income countries, and look at that diamond at the bottom there, you can see that it just overlaps that line, which means that even though it suggested an increase in stillbirths, it was not statistically significant. So highlighting a difference between different types of countries. Interestingly, just by the way, another indirect effect of the pandemic, if you look at ectopic pregnancy and ruptured ectopic pregnancy during the pandemic compared to pre-pandemic, 6 times the increase of ruptured ectopic pregnancy. And that's fascinating. And that suggests that women who would normally come to hospital with symptoms in early pregnancy were staying at home for the reasons that I said. And we were seeing similar things happen in the rest of the population. Reports of an increased deaths from ischemic heart disease because people would not come to A&E, and strokes and so on. So this was suggesting that pregnant women were behaving in the same way, afraid of going to hospital, as people who are not pregnant. As you might expect, we found that anxiety and depression were significantly increased during the pandemic, not just for pregnant women, I guess, but for everybody else in the world. Okay, meanwhile, back on in our obstetric units, in our maternity units, what was happening? What was the effect of the pandemic? Well, by and large, it was the same number of pregnant women coming through. In fact, last year in the United Kingdom, we had a slight drop, a slight fall in the number of women giving birth. But the real issue was fewer staff, especially at the start, because some staff were getting sick. And of course, when there wasn't freely available testing at the start, if somebody got a bit of fever or a sore throat, they were having to go off and self-isolated. Even if a member of their family became unwell, they had to go off. Not only that, but we had a lot of people being redeployed. So a lot of our junior doctors redeployed to help out in intensive care or accident and emergency. On the other hand, a lot of the elective gynecology work was cancelled, in your country as well as my country, which meant that we had extra gynecologists helping out on the labour ward. How much help that was, I'm not quite sure. The other issue we came across is fever, as you know, is common in labour. So every time somebody got a fever, we had all the problems with isolation, PPE, especially before we had access to rapid testing, which took a long time to come along. And it's fair to say that PPE, protective clothing, caused a huge amount of anxiety and stress in this country, and I suspect did in many other countries. People didn't know whether we should be wearing PPE in the first stage. Was there a risk of getting infection in the second stage when the woman was pushing or shouting? At the start, I'd never heard of an aerosol generating procedure, an AGP, but I quickly became an expert on it. We didn't know at the start whether the use of Entonox was an AGP. It is not. There were real problems around neonatal resuscitation. The neonatal doctors, when they came in, they would wear full PPE because they said, well, we're ventilating, we're intubating this baby, that's an AGP. In the meantime, the poor midwife who'd been with the woman for 12 hours and in the same room while the baby's been resuscitated was just wearing a simple mask and visor. So lots of stress and anxiety. And then in terms of cesarean section, because of the time it takes to put on the PPE, we were suggesting earlier epidural in women where there was an increased risk of cesarean section in order to avoid the risk of an urgent general anesthesia, and that, of course, being an AGP. And then a reduction in the services that we were providing. Most units stopped providing water births because of perceived risk of infection. Home births were stopped because of the demand on midwife numbers, and midwives had to be kept in the hospital because we had so many people off sick or self-isolating. Partners were stopped coming in. That created a huge amount of controversy in the United Kingdom. They are now back on the labour ward and at births, although still restricted in postnatal visiting. So a lot of stress and tension around that. And then the huge change that we've seen right across the world in terms of a changeover to virtual appointments. And I'll talk more about that in 1 second. A slight reduction in ultrasound scans. We still do the essential ultrasound scans, but the kind of nice extra scans had gone during the pandemic. We wanted to avoid glucose tolerance tests because the last thing we wanted was a pregnant woman sitting in a hospital for 2 hours, risking infection for herself and for the healthcare staff. And then something that we should have always been doing, which was making sure that if a woman needed a scan and a visit to the hospital, to the doctor, and a visit to the midwife and a blood test, that everything happened at the same time, on the same day, rather than bringing the woman back for repeated appointments. And then home blood pressure monitoring. The government made a huge amount of money available for buying and distributing home blood pressure monitoring kits. And then there are lots of apps, home blood pressure, mobile phone apps and instructions that you can use. So the woman checks her own blood pressure at home, plugs it into the app on her phone, and her phone says, go to hospital, or you're fine, or repeat your blood pressure in half an hour and see what happens. So lots of steps to make sure to minimize the number of visits to the hospital. Now, virtual appointments have their advantages and disadvantages. Huge advantages. I mean, the main reason for doing this was to reduce the risk of infection. to both staff and the woman herself, but also huge convenience for women in terms of reduced traveling to hospital, reduced cost of travel, reduced need for childcare, you reduce waiting in busy antenatal clinic waiting rooms. But we have to be aware of the fact that there are some disadvantages, and particularly for those pregnant women who are most vulnerable, who have safeguarding needs, who are prone to domestic violence, who don't speak English in my country as the first language, who are deaf. And there is a possibility that those women, that they will be missed. We will, by not seeing these women face to face, we will miss the little clues, the little visual clues that this woman may be abused or may have some sort of problem that she can't share. I just want to mention briefly the RCOG. We produced from day one, back in March of last year, we started producing our COVID and pregnancy guidance. And at the start, we were updating this once, twice a week, working 24/7. And gradually this evolved. We're on version 12 or 13, I think now, yeah, version 13 now. But it has evolved into a whole suite of guidance, looking at every aspect of obstetrics and gynecology. And please feel free to have a look. This has been used in countries around the world. It's been downloaded more times than anything, any document ever in the RCOG. I think I'll stop there, but it's a pleasure to be here, and I'm happy to answer any questions. Thank you very much.
Pat, thank you for absolutely fantastic lecture. I think you brought together all the information what happened last year, about the impact, what happened, and I think I haven't heard a lecture like that before, which comprehensively looks at the whole issue. I think that every extreme, and this was an extreme, what happened last year, and it was unexpected, and we were unprepared, causes things you mentioned. And there are positives and negatives on all these things, as you mentioned. And I just might be a little bit afraid, and this is what I'm asking you, about judging and about making fast results, about, like, let's say, miscarriages and increase of something, because we are still, this is a very fast situation, and I think we should, my opinion is that we should wait another 2-3 years and then to make a judgment of the situation statistically. But definitely it was something what was unexpected. What do you think about that?
Yes, I think you're absolutely right. I mean, the way that medical knowledge usually evolves is that you get one paper that says something, and then the next year you get another paper that says the opposite. And after about 10 years, finally you come to a conclusion. And I think Martin's going to talk about the statistics about this in a minute, which I think will be very interesting. But I think it's also true that when there's an information vacuum, then the people out there will fill it with false evidence, false stories, etc., etc.
That's it. Yeah.
You look, for example, at the stories around vaccination and fertility, for example. So, on the one hand, we doctors, we want to be completely honest and transparent and say, we don't know the answer to this question, and this question just yet. Hold on. But at the same time, if there's an information vacuum, then people will try to fill it. So I think we've been doing our best to strike a balance between publishing good quality data as soon as it's available, but at the same time trying to squash the bad quality small studies. And even when we published that initial stillbirth study, we were very honest. I mean, people criticize us and say, how can you publish this? This is scaring women. And we said, well, yes, but we have been very honest and said, look, this is small numbers, this is one center, this is only a few stillbirths, but look, let's just be open to the possibility and let's have a look at some national data and see if this is a true effect or not.
Oh, thank you. I think it's extremely interesting what you mentioned about the extrauterine pregnancy, because this will be the real cause, and I do really believe that it is like that, because the patients just do not go to dentist with the pain of the teeth. And unfortunately, we had a case here of a celebrity guy who died on non going to the dentist because he was afraid, and then he was senior and he got septic, so it's a disaster. Yeah. So this is the delay in care which which caused many side effects. Okay, thank you very much. I think that everything was said in your presentation. Perhaps patients ask us a lot about vaccination today and pregnancy. What do you think about what evidence we have for that?
So I think Martin is going to speak about this, so I'll just speak very briefly about it. Now I'll just say what the RCOG guidance at the moment is that if you're going to have a vaccine, sorry, let me rephrase that. When you're offered to have a vaccine comes based on your age group, the fact that you're pregnant should not put you off having a vaccine. But if you do have a vaccine, go for the Pfizer or the Moderna, because that's the one where we have the evidence from the States. Not that we're concerned about AstraZeneca or others, but just we don't have the evidence to back it up. But maybe I'll leave that to Martin. I think he's going to speak about that in a bit more detail.
Okay, and what do you think about vaccination in the first trimester? Do we have some evidence?
I don't think there's any evidence that it's a particular risk in the first trimester, and that's looking at the data from the States as well. Now, people will argue, well, we don't have long-term follow-up data on these babies. On the other hand, if you don't have the vaccine and you get COVID in the first trimester, there's a risk there, and we don't have long-term follow-up on those babies either. So, I think it's a very personal choice. But at the moment, I would say, or at least our guidance is that there is no reason to avoid it in the first trimester, as far as we know at the moment.
Thank you for this information. So, Pat, I think we are done. Thank you very much for the fantastic lecture, and
thank you very much.
Hopefully, you manage for the Q&As at the end of this session.
Thank you very much indeed.
Thank you. And it's my honor and pleasure to introduce my friend and colleague. It's my honor and pleasure to introduce my colleague and friend, Dr. Martin Hinek, who is